Psychedelics have been a part of the human story for millennia, from the mind-altering brew known as kykeon, consumed in ancient Greece, to ayahuasca and the Amazonian traditions of indigenous people. And now, after years of prohibition, we find ourselves in a psychedelic renaissance that is rediscovering the medicinal and therapeutic potential of the plants and compounds revered by our ancient ancestors. This revival is exploding in popularity. We have MDMA showing promise for PTSD, Psilocybin tackling depression and end-of-life anxiety, and even ketamine lifting severe mood disorders, blending the cutting-edge science of today with the timeless wisdom of yesterday. Today, I sit down with Dr. Emma Hapke, a trailblazing psychiatrist and researcher at Toronto's University Health Network, as well as a protege of Paul Groff, who was a pioneer in psychedelic therapy. Frustrated by psychiatry's limited tools, she has become a central figure in psychedelic-assisted therapy for trauma survivors. She led the MAPS Canada MDMA trials and now drives psilocybin studies for cancer patients facing mortality. In our conversation, we dive into psychedelics' deep history, the FDA's controversial rejection of the MAPS MDMA trials, the rigorous therapy process, and the hope and hype surrounding this promising approach. Join me in Vivo with Dr. Emma Hapke on psychedelic-assisted therapy. Dr. Hapke, thank you so much for joining me.
Thank you for inviting me. It's a pleasure to be here.
The reason why I'm so excited to speak with you is because there's been this tangible explosion in interest of psychedelics as a treatment for mental disorders. And I'm admittedly one of those people who's super interested in it. I mean, we have MDMA for PTSD in trials, psilocybin for depression, and a whole host of others. Mm-hmm. And as an external observer, I've seen so many fascinating and interesting stories and claims on podcasts and the like of people that have gone through this experience. Mm-hmm. I thought it would be great to get somebody who's actually on the ground floor dealing with this modality and speak to you about what it's all about, who can do it, look at the hope and the hype and that sort of thing. So why don't we start with a little bit about yourself? Who are you? And how did you get drawn into psychiatry and specifically psychedelic assisted therapy?
Sure. Yeah. So thank you so much. It's really a pleasure to be here. Hi to all your listeners. So my name's Emma Hapke. I always say, at least when I'm introducing myself professionally, that I'm a psychiatrist by training, a psychotherapist, because not all psychiatrists do as much psychotherapy as I do in my practice, and then a psychedelic researcher. And so those are kind of like the three hats that I wear professionally. And when I was in medical school, I was just really drawn to people. Like, people fascinate me, what makes them tick, their wounding, their strengths, their resilience. And I wanted a specialty that gave me the time to really dive into being able to really get to know people. And the one thing about psychiatry is, like, no two cases are the same. Other areas of medicine can become a bit rote. They can be technical.
A little more textbook.
Yeah. So it's really, there's a lot of art in psychiatry.
Oh, that's interesting.
And so, no two people with depression are the same, and their life histories are different. And like, the minimum appointment times are an hour, when you're first starting to get to know someone, or longer. And so that really drew me in. But then as I continued my training in medical school and psychiatry rotations, and even in psychiatric residency, I started to struggle because a lot of the tools in psychiatry are really blunt, and they, to be frank, they don't work for a good subsection of our patients.
Are you talking about medicine?
Mostly medicine. That's like one of the main tools of modern psychiatry. Mm-hmm. Now, I want to be very clear. They do work for some people.
Right. Yeah.
And so, maybe like 40% of people actually do get a benefit, and they're really important tools. And combined with psychotherapy, they can be great for lifting people of depression, anxiety disorders. Antipsychotics have their role in treating psychosis. But there's a significant subset of patients that are not helped by our current tools, and they're called treatment refractory. I don't even like that term because it almost makes it sound like it's their fault that our tools don't work for them.
Yeah.
And so my first job after residency was at the Center for Addiction and Mental Health, and I was working on the women's inpatient unit. And while I was there, so these are working with women who had experienced a lot of trauma, often starting in childhood, and then all the kind of later effects that come from a lot of adversity when you're young. So mood disorders, suicidality, addictions, self-harm, that kind of thing, and post-traumatic stress. And when at CAMH, a lot of these patients were like at the end of the treatment algorithms. There was like nothing left. They had tried multiple medications. They were still really symptomatic. Sometimes the doctors on the ward would use electroconvulsive therapy, but because of some of the side effects of that treatment, the patients then couldn't really engage in psychotherapy. And I was finding that, especially for people with a history of trauma who were hurt in relationships, then they also need to heal in relationships. And so the psychotherapy to me was really central to the healing. And so I wanted to find treatments that where the patients could continue to engage in psychotherapy, but we also, psychotherapy is expensive. It's often not covered in the public system. And
can you define that for us, psychotherapy?
Psychotherapy is really just, I guess, a form of treatment where you have there's a lot of different modalities of it, but you basically have two people who are talking, and one is a patient, and they're, in various different ways, we're trying to explore, unpack what's going on, their emotions, their past trauma, processing that. Yeah, there's so many different modalities, but that's sort of the basic
behavioral
idea.
Therapy falls under that?
Yeah, so one modality would be cognitive behavioral therapy, where you kind of look at where your thinking is getting stuck, how to shift some of your behavior. It includes kind of like exposure therapy to like face what you're afraid of. That can be quite effective for certain anxiety disorders. Yeah.
Right. So then how did you find yourself researching and dealing with psychedelics?
So as I was on this ward, I was like, we don't have forever to do long-term psychotherapy, and we need to lift these patients out of these really extreme states. And so I ended up being mentored in the field. Is one of the sort of pioneers of psychedelic therapy is named Stan Groff, and his brother, Paul Groff, was a psychiatrist at my hospital.
Oh, is that right?
And he started mentoring me in how to give ketamine assisted psychotherapy.
So his father's the one that came up with holotropic breathing.
So his brother. So Stan and Paul are brothers.
Right.
Yeah.
Right. Brother.
So they're both in their 90s now.
Yeah.
So Paul started mentoring me in how to use ketamine-assisted psychotherapy, and we started using it on the ward. And we were getting really, great results. Mixed, didn't work for everybody, but for some patients, it really helped their suicidality. It helped them get in touch with like deeper parts of themselves, start to process their trauma. It would lift their mood. And so that really kind of whet my appetite. Like this is something really unique. And it was really exciting to me. And so through a series of, I'll say synchronistic events, I ended up on a phone call with Rick Doblin.
Right, from MAPS.
Who started the Multidisciplinary Association of Psychedelic Studies. And they were running these phase 3 trials studying MDMA, which is the active ingredient from like the street drug is called ecstasy. And they're combining that with psychotherapy for the treatment of post-traumatic stress disorder. And so I ended up becoming the principal investigator of one of the sites in Montreal. And so we led that study. That was a really great opportunity for me to learn about clinical trials, how to run them. I was also trained in how to deliver MDMA therapy. And again, we were getting some really promising results in that trial.
We'll get back to MAPS a little bit later with that recent sort of kerfuffle with the FDA.
Right. Yeah.
I think I love science history, and this is a unique one. It's interesting because modern science is sort of rediscovering something that has been known in practice for thousands of years. Can you tell us a little bit about the history? And I'm talking about deep history of psychedelics in terms of culture, religion, call it medicine, if you will.
Yeah. I mean, when like you look at like the historical record, like humans have been altering their consciousness with plants and fungi for like thousands and thousands and thousands of years. And, in more recent times, it's been really indigenous communities that have been stewarding and continue to kind of cultivate those traditions. And, we can talk about what some of those are. In terms of Western history, we have the Eleusinian mysteries, which were these rituals that took place in ancient Greece for about 2,000 years, starting around, I think, 1600 BC. And what was interesting is all were welcome, from like emperors to poor people. And there's pretty good historical evidence at this point that they were imbibing this potion called kykeon, which likely contained an ergot-based psychedelic. And these rituals were about death and rebirth and coming out of the delusion of individuality and connecting to the divine. And then, I think there was also a history in Western Europe of like witches and cunning men that got really suppressed during the Inquisition. And a lot of that knowledge really was successfully eradicated by the church.
And Northern Europe as well with the Celts.
Right, exactly. Right? And Russia, there's a shamanic tradition. So this seems like we actually see it all over the world. it's something that it seems, and it's not even animals will take psychoactive
Yeah,
plants. I
right.
can't even say it's
Yeah.
uniquely human.
That's right.
And in indigenous cultures, there's, it's not just for healing. They're often using plant medicines to connect to something bigger than themselves, to connect to the divine, to connect to the community. They use it for rites of passage. They use it for hunting, for initiation. So there's lots of different uses. And then it is also used for healing.
Yeah. If anybody's interested in that, there's a great book by Brian Murarescu, which I've heard you speak about, The Immortality Key, sort of cataloging all of what you just described in terms of culture, religion, and that sort of thing. Fascinating. Now, in terms of, I guess, more recent history, because I mentioned rediscovering by modern medicine, we have Albert Hoffman, right? He's the kind of the first legendary. Was he a medical doctor?
He was actually a chemist.
He was just a chemist. He was not a clinician.
He wasn't
put it
a
that way. And he discovered LSD.
That's right. Yeah.
Right. There's a funny story about how he discovered it.
Yeah, I mean, so I also studying ergot-based derivatives. He was, I think, looking for a medicine that was either like a respiratory stimulant, and he synthesized LSD. He was doing a bunch of molecules. It was number 25, and I think this was in 1938. And he sent it, and apparently it was tested on animals, and they were just told there was no unique properties, so it was shelved. And in his book, LSD, My Problem Child, he talks about having this intuition that there was something special about LSD 25. So in 1943, he resynthesized it, and a little bit went on his finger, and he started to feel really strange. And so the next day, which was April 19th, 1943, it was during the war, he intentionally ingested 250 micrograms, thinking this would be a very small dose.
Okay.
But LSD is so potent that that's actually a really high dose. And so he was the first person on that day to have like the world's first real
synthesized concentrated
LSD acid trip. And he was really high, and he had all kinds of crazy experiences, and his assistant had to bike him home because it was the wartime. So it's now celebrated as Bicycle Day.
Bicycle Day.
Yeah.
Okay.
And so he then realized there's something really unique and special about this molecule. And so he started Sandoz started distributing it to researchers and clinicians all over the world to start experimenting with it. And so that was really the beginning of that kind of era of psychedelic research in the 40s and 50s.
So you mentioned ergot. Just to define it, I guess, for the listeners, that is a fungus.
I think it's a fungus that grows on grains.
Grains, right?
Yeah.
Yeah, so pretty much ubiquitous all over the world. It's interesting, when you think back to whether it's ergot or beer or wine or whatever it might be, first person to ever come across that. Isn't that fascinating?
It's so interesting to think like about how humans discover this. Like even if you think about the plant medicine ayahuasca, right?
Yes.
So it contains two different plants. So you have the vine, which is the ayahuasca vine, and what that contains is this called an MAOI inhibitor. So it blocks your stomach from breaking down dimethyltryptamine, and then it's combined with a plant called chacruna, which contains the DMT. And so it's like, how did the original people who discovered this figure out to combine these two plants to create that?
In a place where the diversity of animal life and plant life
really
is just through the roof.
Yeah. So the indigenous cultures would say the plants told us.
The plants told them prior to even taking it, right?
Yeah, exactly.
Yeah, actually, well, there's another fascinating story in terms of technology discovery. Now his name slips my mind, but it's a gentleman who discovered PCR.
Okay.
Have you heard of that story?
It's ringing a bell, but it's not coming to mind.
So I'll put it up on the screen here, but he apparently had some sort of intuition while driving through the Californian hills, high on LSD, stopped his car and had an epiphany moment and wrote it down. And from there we get PCR.
So interesting. Yeah. They were doing some interesting studies in the 50s and 60s where they would give like creative people from different like philosophers and engineers, people who are trying to solve high level problems, they'd give them high dose acid. And initially they'd be sort of journeying, but then as the, medicine was coming down, they would then bring out their problems and actually work on it with the support of the medicine. And they found it increased like creativity and being able to look at the same problem from a different angle.
Right. And then, so if we fast forward a little bit in time after Hoffman, Groff, Timothy Leary, of course, being a huge figure in the psychedelic movement, we have the war on drugs. Right. And from that point on, and that was in the 70s up until the 90s, there was basically a cessation of all research, legal research at least. And that would you say that set back?
Yeah, I think we got set back probably 2 to 3 decades by the kind of the war on drugs.
Yeah.
It was sort of, I think LSD became scheduled in 1968 in Canada, and it was 1971 that like the war on drugs was officially declared. Timothy Leary was declared to be the most dangerous man in America, and the UN kind of had a resolution that all of these drugs should be restricted.
His what was his motto? Tune in,
turn on, drop out.
Right? Yeah, and then of course Charlie Manson and that whole thing didn't help.
Right, and it got really, LSD got connected to the counterculture and to like the resistance against the Vietnam War. And so some people believe that like the restriction was also about, controlling society.
Of course. And what's interesting, and I wonder how many of these people who put these restrictions in place were on the side dabbling in these things.
Mm-hmm. You wonder about that.
Of course.
It's interesting. So it was the Canadian Controlled Drug and Substance Act, called the CDSA, was being kind of legislated for the first time in like the very late 1960s. And it was actually Senator Molson, the Molson Brewing family, that advocated that alcohol was safe and should not be scheduled. And same thing with tobacco, but LSD should be. And so we now know the harms that come from alcohol and tobacco.
And now you're using psychedelics to treat alcoholism in some cases, right? Isn't that ironic?
So it's interesting.
So let's move into what exactly you do from a research perspective, but also I'm really interested in the clinical aspect.
Sure, yeah.
Because we hear about it all the time in podcasts, like I mentioned at the top. It is fascinating. You hear of these stories of people that go through these experiences and are, seemingly cured of their ailments, whatever it might be. But we don't necessarily hear about what actually goes on.
Sure, yeah.
So take me through the process, I guess. So first of all, who's a candidate for this, and where do you start with somebody?
Yeah. So, I mean, the screening process is really important. We have pretty exhaustive screening. Right now, we're running a clinical trial that's treating patients with advanced cancer. And so it's a high-dose psilocybin therapy that helps people who have a lot of fear of death or a lot of unprocessed grief, or just there can be a lot of distress that comes with, dying or at the end of life. So when we're screening people, we kind of look at what's going on with them medically and then also psychologically, psychiatrically. Medically, psilocybin's actually really physiologically safe on the body at the doses that we're giving.
Right. Huge LD50.
Yeah, absolutely. So, it does increase your heart rate by about 20 points and your blood pressure. So we need to make sure their cardiovascular system can tolerate, mild to moderate exercise. You have to have enough liver function because a lot of these are like being metabolized at the liver. Try to stay away from people who've had like really recent like bleeding or seizures or confusion. But we've treated patients that even just like a few weeks from the end who are very quite medically ill, and they've so far all done really beautifully. And so I think we're really still learning about like, how can we push the envelope? We treat, of course, in Toronto General Hospital where you have medical backup and we collaborate with people's specialists. Yeah. So that's on the medical side. And then psychiatrically, like one thing is this is a very different modality than, let's say, taking like a SSRI for your depression, where you take a pill, and some of that's about kind of symptom management, kind of in a way pushing things down so you can carry on. And there's absolutely nothing wrong with that. But psilocybin therapy, which is really what I'm focused on right now, is very different than that. And so psychedelics are non-specific amplifiers of the psyche. And so what they do is they actually give you greater awareness to yourself, including potentially very difficult things that have been pushed down, past traumas that haven't been processed, emotions that haven't been metabolized. And so we really want to make sure that people understand what they're signing up for, that they're signing up for sort of a depth-oriented psychotherapeutic process on steroids, essentially. It's a very experiential. And so sometimes in the media, I think there's been kind of a narrative that this is a brain reset. And I think that sometimes that can kind of create the impression for people that their role is passive, that they're going to come in and take this medicine, their brain's going to reset, new neural pathways will form, and they'll be feeling better. And actually, it's really hard therapeutic work that's accelerated by the medicine. Like I really see the medicines as catalysts for this deep work. And so we want to make sure that people understand what they're signing up for. can they form enough of a trust and rapport with the therapist? Are they prepared for going inward, knowing themselves better, processing past trauma and intense feelings? A lot of those experiences can be really healing. They can be cathartic. People let go of stuff. They often feel a lot better on the other side. But we really want to make sure that we're educating them so they understand what they're signing up for.
And this is, as the name would suggest, combined with psychotherapy.
Exactly.
So you're there in the room with them while they're having this experience.
At least how like our kind of ethics and values and approach to the work is that this is psychedelic therapy, and it's a complex intervention, and there's like multiple components that are leading hopefully to the positive outcome. So you've got the modality that you're using for the therapy sessions, even without the medicine. You have the therapeutic relationship. You have the patient's own like inner healer and their own, and like we call it their inner healing intelligence. And then you have the drug, which catalyzes all of that.
Right.
And so a typical therapy, like in our end of life trial, there's an intensive screening process, and then you'd have 3 to 4 preparation sessions without any drug that are done over the course of about a month. And during that time, we're really getting to know people, building up that trust and rapport. We go through a pretty detailed life history. And one of the flags we're looking for, if like people are not willing to look at their childhood, once they're on the medicine, they may have no choice. So we're kind of paying attention for how they are when they're kind of, how avoidant are they? Are they able to talk about their past? And that can be really important for people to feel really seen for the first time and to have such a detailed history taken. And then there's usually 1 or more high dose psilocybin or MDMA, depending on the modality sessions. Typically in the field, there's 2 therapists that are actually present for all the prep, the dosing, and the integration. So we are currently using kind of a 2 therapist model. That's the standard in the field currently.
So, pardon me. Going back to the more ancient history, where you had shamans that would sort of guide individuals through these experiences. Seems like you're kind of doing the same thing.
It's a little different, actually. Like typically how it would work in Indigenous cultures previously is that only the shaman would take the medicine.
Oh, interesting.
And they would get messages about what was going on with people. They sometimes had the people in the ceremonies, they would be able to like diagnose what was going on. They would get messages for them from the spirit world, but it wasn't actually the people, the patients, the people seeking healing that would take the medicine themselves. Now that's
interesting. I've never heard that.
Yeah, that was kind of more typically how shamanism was practiced in Indigenous cultures. Currently, with this whole kind of tourist boom of ayahuasca, everybody takes the medicine now, but that's actually not really how the typical lineages would work.
So how much of what you do and teach, and also those who are being trained, reflects what the shamans are you actually are you going back and looking at what they used to do or what they're currently doing and adapting some of that into your practice? Is there a parallel?
It's a good question. I think that how do we honor the Indigenous lineages without appropriating them and bring some of this into a biomedical Western context, a totally different culture? These are questions that I think the field is grappling with. I will say that personally, I have worked with ayahuasca myself or my own personal healing for many years. And so it has seeped into not only my worldview, but I think how I approach the work in terms of how we train people, how we hold the space, the openness to the spiritual aspects of the work. Because these medicines really do open up people to something bigger than themselves. And we're never imposing any form of spirituality on them, but we want to create a safe container for them to discover their own connection to something bigger than themselves and their own definition of what spirituality means to them.
So if you don't mind me asking, what percentage of clinicians such as yourself would take that approach in trying the experience themselves so that they have a better connection?
It's been like debated in the field whether this is necessary. We actually wrote a paper, which I can flag here, on the risks and benefits of experiential training. So some people argue, I would say like more people in the field, I don't know, this is really just me guessing, maybe like I would say probably 75% of psychedelic therapists have had their own experiences and would say it's important. Sometimes people have equated it to like a wilderness guide. Like if you're going to go into the wilderness on a guided trip, do you want to go with someone who's never been before, who doesn't know the terrain?
That makes sense to me.
So that metaphor is helpful. People have argued maybe it makes people biased. Sometimes maybe these people are, psychedelic evangelists or believers. But I would argue that often therapists do have an inclination towards the modalities. Like it's actually a good thing if you believe in the modality that you're working with. I don't necessarily see that as a problem. I think we need to be very aware as researchers of bias. We all have bias.
Yeah. That's a similar idea is, I'm diabetic.
Yeah.
And I always wonder about endocrinologists who are not diabetics themselves, and whether or not that would make you a better endocrinologist. Right. Yeah. Having an experience with dosing and the whole deal.
I will just say on that point, like a lot of other kind of depth-oriented modalities, like if you're going to be a mindfulness teacher, like you have to have a meditation practice. If you're going to be a psychoanalyst, you have to be analyzed. So there is a precedent for have experiential training for different modalities.
Right. Yeah. And you can apply that maybe to like a personal trainer too.
Yeah, exactly. Exactly.
Right.
Yeah.
So I'm curious because you do psilocybin. Oftentimes, if we're talking about recreational, you hear 2 grams as being sort of the dose.
Yeah, maybe kind of like moderate. That would be like a moderate dose.
What are you dealing with?
We actually give pretty high dose. Yeah, it's pretty standardized at this point. So we give 25 milligrams of psilocybin, which is about equivalent, we think, to around 4 grams of dried mushrooms.
Right,
so
because you're dealing with concentrated psilocybin, right?
Yeah, so it's synthetic. We work both with synthetic and also a company, Filament, gives us it's a botanical extract. So we have 2 different products. But yeah, it's just pure psilocybin in a pill. But it's a high dose. So it's designed, but, with a lot of support, people can surrender and let go. And we're getting really great results in the end of life population with this dose.
So I would imagine, because you are spending so much time with these patients at a very critical juncture in their lives, many visits and long visits, how do you deal with you developing a relationship with a patient and the patient developing a relationship with you? That must be difficult to try to put up a barrier, or do you not put up a barrier?
Can you say a little bit more about what you're trying to get at?
So I would imagine that if you have somebody coming in and you're spending a lot of time with them, that you start to develop a relationship. I don't mean an inappropriate relationship. It's just that I would imagine you get closer to these patients than a family doctor does.
Yes. Right? I think I know where you're going. That's actually, it's a really astute point, because in therapy, we call these feelings that develop between the therapist and the patient transference, which is how the patient feels towards you, and countertransference, which is how you feel towards the patient. And what we find in psychedelic therapy is both of those processes are intensified because it's so intimate. Yeah, and a lot of trust is built up. And so the safety is really important. And one of the things that's really important is, how does the therapist care for themselves? Because it can actually, the intensity of the psychedelics can actually like put you in a bit of a non-ordinary state yourself when you're sitting there, even without taking any medicine. Right. Just like the energy in the room can be actually quite powerful. So it can bring up your own shadow aspect, stuff that's unresolved in you. For our group, if we're working at the end of life, like you really have to work through your own relationship with death as much as you can, so that you can hold the space cleanly without your own stuff kind of infiltrating. And so, I think intense intimacy is formed, and that's something that I think the field is still grappling with, is like, especially in the clinical trials, like how do we use the term terminate someone from a clinical trial, which is a terrible term, but like, how do we, when people have connected to us so deeply, and that's this very special kind of bubble, and then the 2-month trial is over, and how do we make sure that they're getting the support that they need? Yes. And one of the things that I think we're still learning is, for some, it's a small percentage, probably like under 5%, there can be like enduring negative effects. And so how do we follow people long term, and what are some of the models that we can use? So at our center, we're going to develop an ongoing integration group, for example, so people can continue to just come and be part of the community and meet others who have done this kind of healing.
Is most of this therapy outpatient?
Yeah.
Okay. Yeah. And so if somebody, how does one get involved or enrolled in such a therapy? Is it a family physician writes a script, or
We're
Senza?
not quite there yet.
How does it work?
Right now, the main way that people are accessing psilocybin is through clinical trials.
Okay.
And that's, I think, important to know that it's still experimental. So people are signing up for an experiment.
Yes.
So here in Toronto, there's like a big program at CAMH that has a variety of psychedelic trials. There's 2 programs at University Health Network where we work. There's a community-based program that's looking at MDMA for PTSD in the community called Remedy. And so people can self-refer to these clinical trials and be screened. So that's one way. There is something called the Special Access Program, where the government is allowing physicians to prescribe psilocybin on a case-by-case basis for certain patients. So we can use it for treatment-resistant depression and end-of-life distress, and also MDMA for PTSD.
Is that without therapy?
It's with therapy, but it's not part of a clinical trial.
I see.
Yeah, but it's still with therapy. And so it's still very much like you go to a clinic and you're working with therapists and you have your dosing session. And then ketamine is a bit of a different story because it's its own. It's already been approved as an anesthetic, and so it's
been around for a long time.
Yeah, exactly.
Right. So those are the 3 big ones: psilocybin, MDMA, and ketamine.
Yeah, right now. Yeah.
And you've worked with all 3.
Yep. Yeah. Mm-hmm.
And which one? And there. So MDMA is classically for PTSD.
Mm-hmm.
Psilocybin for depression, and ketamine would be for.
Ketamine is used also, like it's approved as a treatment for treatment-resistant depression. It's really good for acute suicidality. So it's primarily used for mood disorders. However, it's also can be quite good for post-traumatic stress and helping people process trauma. And I would say psilocybin, it's really interesting. It works for a variety of different things. And it works for a lot of disorders where the mind gets stuck in these like repetitive patterns of thinking, which then lead to repetitive behavior. So it's showing a signal for obsessive compulsive disorder, for the rumination and depression, for the perfectionism of anorexia. It also does cause this kind of pretty powerful behavioral reset. And so it's showing pretty promising early results for addictions as well. And then I'd say the final big one is end of life distress. So psilocybin's really used kind of transdiagnostically.
Are there any trials dealing with ayahuasca or DMT?
Not ayahuasca in terms of like taking that out of its lineage, out of the jungle into the clinic. I think that people are looking at another form of DMT called 5-MeO DMT that's being studied for depression and other indications, and NN-DMT, which is the active ingredient in ayahuasca. So there was a trial at Imperial College where they were giving people IV infusion. These were healthy volunteers, but they're giving them IV infusions of NN-DMT
continuous
to be in this
DMT
extended state.
Right.
I think they were really interested both in what was going on in the brain, but also with the subjective phenomenon where people were experiencing.
So you mentioned earlier Rick Doblin and MAPS.
Mm-hmm.
Why don't we talk about what happened recently? It was in
Sure.
June of 2024. The FDA decided to, deny.
Yes.
Deny. What would you call it? Deny.
So it was called like and it's a new drug application,
Right.
NDA.
Yes.
And so, we thought the science was really solid. And so this was somewhat of a surprise. And it was actually quite recently that the FDA released what's called the CRL, which is the complete response letter. So we now actually know what some of their concerns were.
Yes.
I think just to give a bit of the context. So MAPS was initially a nonprofit. It raised $150 million in pure philanthropic donations to move MDMA through the drug development process. And they made it almost to the end of phase 3 before they ran out of money. And so at that point, it pivoted to become a for-profit called Lykos. And that was towards the end of the second phase 3 trial. And I want to start by saying like the results that we got in these trials were really solid. So we were treating people with severe chronic PTSD. They had PTSD for an average of 15 years. They had failed other treatments, and 67% no longer met criteria for PTSD in the active group.
Is there a current accepted treatment for PTSD in terms of a pharmaceutical?
There are a couple antidepressants that are approved, but they're not. Their effect size isn't that significant.
That was my question.
Yeah.
The 67%
That's
is
like way higher than what we have. Yeah.
Okay, so promising.
Very promising. And actually, like the safety profile is quite good. Like it actually, what we were seeing at these sites, I was involved in these trials, is that like for most people, this is quite safe and effective. So the AdCom voted against approving it. The FDA didn't have to go with that decision, but they typically do, especially when the AdCom says no. I will say the advisory committee many of these people didn't have any understanding of psychotherapy or psychedelics. And even they were saying we're out of our lane. And you could see the stigma in some of the people in the committee. One physician was worried that like people would take MDMA in the trial and go home and do cocaine with their partner. And so you see some of the anti-drug stigma. But anyways, so the FDA declined to approve this NDA, and now we have the complete response letter. So their concerns, one was that we didn't record positive adverse events. I think that this was maybe part of just going first and being the first out of the gate. So for example, we didn't record euphoria as an adverse event. But
is that something that's commonly recorded? I've never heard of a positive adverse events.
So they're saying it could increase abuse potential. I think this is where it's actually really challenging to like figure out how to record adverse events in psychedelics, because so many of the effects are actually part of how it works. Like, for example, I have to record like grief, except like processing grief is how the patients get better. Right. But from like a side effect profile. So there's a bit of a paradigm clash, I think, that's going on. So they were concerned about that. I think that the argument is we actually have pretty good like evidence about the abuse potential of MDMA, and it's not like compared to other drugs they've approved, like ketamine, much more addictive, benzodiazepines, opiates. Like they've approved way more addictive drugs than MDMA. We know that it can be abused, but it's not a common drug of abuse. Their other concern was that 40% of the patients had previously taken MDMA. And so they were saying that's a selection bias. They're more likely to be unblinded. They'll know what it feels like to be on MDMA. And they're more likely to think that it had a positive effect. Right. When we looked at the data, though, the people that had taken it before and also hadn't taken it before did equally well. Right. And I think it's important to remember that it's not just it's not just the drug, it's the whole therapy. It was 3 MDMA sessions, 12 other psychotherapy sessions, an 18-week protocol. And so people taking it recreationally, it's like a very different experience than taking it with the intention of processing trauma and healing. That was a concern. I will say that, again, that's like I think a clash. Like the reality on the ground of like trying to run these clinical trials is that clinically, the people that are more drawn to trying a psychedelic often are more open to new experiences and very often have tried psychedelics. Like even in our cancer population, I would say half our participants have taken psilocybin before. And in a way that makes them, I think, better candidates. They actually know what they're signing up for. They understand the terrain a little bit. Right. So, but I understand that's the clinician in me talking, but from like a research perspective, to have a really clean sample, it is better data. And so that was part of their argument. Right. I think what you're describing in statistics is, would you call it a confounding variable or a confounding aspect or situation? But you're right. I mean, that makes total sense. I got a question for you in terms of protocol, because I think it's lost on people when they think about this situation or psychedelic therapy in general. It might be lost on them, the therapy aspect that we're talking about, the psychotherapy. So when you're running a research trial like this, you have how many participants? So the MAPS trial is like the first phase 3 trial had about 90. Okay, I was going to say 100. So 90. So how many, practically speaking, how many therapists are involved with 90 subjects? Well, that particular trial had 12 sites all across the US, 2 in Canada, and you probably have 2 to 4 therapists at each site, even more. What I'm getting at is the possible variability in the way that therapists would do their psychotherapy, which might skew numbers one way or the other. But it's an interesting thing because like you said in the onset. There's adherence. So all the therapists had to do a case before they were part of the trial that was watched by adherence raters, and there's scales and they had to go through a training, and there's a manual. So there's ways to try to standardize it. I mean, I think you're absolutely right that there's going to be variability, and there's also variability in fit, right? Like sometimes there's just a natural fit between a therapist and a patient. Yeah, exactly. But despite that, you still got very good numbers. Yeah. I will say the other thing that the FDA was concerned about was that PTSD is a chronic condition, and we only had data up to 18 weeks, and they wanted us to follow people for longer and keeping them blinded. But ethically, we wanted to have a crossover study where those who got the placebo, the sugar pill, could then get the high dose MDMA sessions, as we thought that was important ethically and for recruitment.
Outside of the research
it's a follow-up study. It's like a crossover study.
Gotcha.
Yeah, but because of the crossover study, that prevents you from being able to follow people for as long in a blinded way.
Makes sense, yes.
And then also we did have a long-term follow-up study, but some of the patients, had now done the crossover. Others had engaged in other forms of treatment. And so it wasn't the data. Was
impossible.
Not super meaningful.
Yeah. So can you speak to the FDA's issue with the functional unblinding? Because I think it's a valid point. Meaning, how do you blind somebody to a psychedelic when you take it and you know what's going on?
This is a big problem in the psychedelic field, and it's going to be a problem like across the board with really any psychedelic. It's actually not unique to psychedelics. I'd say it's more dramatic with psychedelics.
Yes.
But in a lot of drug trials, like even in the trials of antipsychotics, like the patients would start developing side effects and gaining weight, and they can tell when they're on the active drug. So it's not unique to psychedelics, but it's very dramatic. Like it's pretty obvious to the patient, to the therapist who got the active drug. And so this is, again, I think we might have to look at different, we have this gold standard of the double-blind randomized control trial, but then we have these treatments that don't really fit that. And then people say, well, we can never show that it's effective, but it works. And so we might need other ways of generating evidence, like looking at mechanism of action, looking at the brain and how it might change before and after. When MAPS was originally designing the trial, they actually worked with the FDA, and the FDA said one way to reduce this is to have external raters. So the people doing like the primary outcome, which in this case was the CAP-5, it's the PTSD scale. They had no connection to the site or the patient. They were, completely separate. That was one way to try to reduce.
Okay, so
increase
you're
some blinding.
The data. Yeah.
The other thing, so what was I going to say? The other thing is that in the phase 2, MAPS tried comparing low dose MDMA to higher dose MDMA, and that actually did blind people better. But the problem is low dose MDMA makes people really anxious. So it actually has an anti-therapeutic effect. So it would make it look like the high dose is actually outperforming. So it
there might be some ethical issues there too.
That was a challenge. Yeah. So
interesting.
So the FDA actually didn't want MAPS to use low dose MDMA as the comparator.
Could you blind somebody with a different drug altogether?
I think there's been talk about that, like using like methylphenidate or another stimulant, like an amphetamine.
Right.
And in some of the end of life trials, they're using ketamine as a comparator for psilocybin. So there might be other ways to do it. You might find though that like amphetamine assisted psychotherapy actually works too.
Right. It might work as well.
Yeah.
So where does that, so that trial's done now. So Lykos has gone back, correct me if I'm wrong, to being a research.
So they
group.
had to like I think let like 75% of their staff go because they were really preparing for commercialization.
Right.
And so they're back to like being an R&D company. I think it was sold to some new investors. It's rebranded to Resilient Pharmaceuticals. And I think there's going to be independent review of all the data and potentially a resubmission, but also preparing to do more phase 3 trials.
Right. That's interesting.
The other thing that the FDA said in this complete response letter that I think kind of concerned me is they wanted to have an arm where there's no therapy. And I really worry about giving traumatized patients
an arm of the study,
just pure MDMA with no therapeutic component. And I get why, like empirically and like theoretically, that's like valuable. And yet I actually really don't know how ethical it is to give, traumatized patients, MDMA and bring up their trauma and then not support them to process that.
You're asking them to do it recreationally, basically.
Almost, yeah. Right. Like that doesn't like sit well with me. Like our patients needed a lot of support through the trial. We had to add like phone calls every other day in between the sessions. It was really intense inner work and they really needed the support of the 2 therapists. So it's hard to imagine the ethics of that trial. Yeah.
So what sort of research are you currently working on?
Right now, we're working on a trial that it's called PEARL and stands for Psilocybin Assisted Existential Attachment and Relational Therapy. It's a bit of a mouthful, was designed for patients with advanced cancer. And so there's 4 preparation sessions, a high dose psilocybin, and 3 integration sessions. And that we haven't talked a lot about integration, but really what happens after you take the psychedelic is really, also really important. And one of the things that we're learning is that psychedelics open these windows of neuroplasticity in the brain. And so they make your brain changeable for a period of time after. And I think it's important to note that neuroplasticity is neutral. It doesn't necessarily mean you're going to have positive change.
Right.
And that's why we think the integration therapy and the support after is so important to help direct some of that changeability into positive shifts for people.
So this is the neuroplasticity after the treatments.
Yeah.
How many days or weeks after the treatment do you try to jump on that?
I mean, we think from animal models we're learning, but we don't fully know how long is that window open in patients. And it's probably,
and is that after one dose?
Yeah, a single dose, probably at least a month with psilocybin. And so we do an integration session the very next day. And then we're doing weekly integration sessions after that. And we are encouraging people to create space around the experience. Sometimes I like to think of it as a psychosurgery. And just like if you had a big surgery, you wouldn't immediately go back to work the next day. You should rehab. And so we really try to help people protect their environment. And we want to kind of reduce stress in that time so that they're having ideally as positive experiences as possible.
So I think it's safe to say most of the dosing that you're involved in is high.
Yeah.
Right.
Yeah.
What are your thoughts on microdosing?
Yeah. I mean
these 3 things, it's all the thing. You hear the term microdosing in relation to these 3 compounds. What are your thoughts?
Yeah. So, we don't know empirically yet enough about whether microdosing actually works. A lot of the trials, it's not really separated from placebo. That being, this is really not my area of expertise, but anecdotally, people do report that it's helpful. What it is you're taking a very small dose, and it's supposed to be sub-perceptual. So if you're starting at perceptual changes, you're no longer in a microdose territory. So anecdotally, people report it can be really helpful for mood. Even people taking it for ADHD, anxiety. We're seeing it's, I think, becoming more popular. And I think we need more research to actually understand how it works. So there's microdosing, very, very low doses. There's also something called psycholytic dosing, which is where the patient, so in my trials, it's psychedelic high dosing. High dose, so the patients are lying down, they have eye shades on, they're listening to music. It's an inner experience.
This is not a standard hospital room, right?
No, it's very beautifully designed.
Yes, okay.
Yeah, we say it's the nicest room in the hospital. Psycholytic dosing is where you take a moderate dose, but you can still sit up and talk. And so the idea is it kind of loosens the defenses, it lubricates the therapy. So you're still doing talk therapy, but with this, so I've done this with lower dose ketamine, for example. So that's
I've never heard that
own,
term.
Yeah, that's its own. We studied a lot, I think, in Europe and kind of the first wave, and kind of combining. They would do almost 100 LSD sessions with a psychoanalytic therapeutic process for some patients.
What are your thoughts on? So there's a phenomena in Ontario, specifically, I would say in this area, in the GTA. So we know that cannabis is now legal. But you are starting to see mushroom shops pop up that are not exactly above board. What are your thoughts on psilocybin or mushroom legalization? Good idea, bad idea?
I think there's a lot of risks. I mean, I'm really involved in the medicalization route. And so that's really what I'm focused on. And I think for patients who are vulnerable, we need to learn more about the safety. There's still a lot we don't know about, enduring challenging effects. We're still learning about adverse effects. And so I do worry, and some of my colleagues in the Psych Emerge are seeing increased presentations of people taking really high doses of psilocybin that they bought at one of these stores without attention to the set and setting where they're taking them. So I think there can be real risks. I'm kind of split on this because then there's a part of me that's as human beings, I think we have the right to alter our consciousness with nature. That's part of nature, which we are part of.
Access in general.
Yeah. So, but I think we need more psychoeducation. These are powerful medicines and people can get really hurt.
So speaking of education, you as educator yourself, you're an assistant professor. How much of this makes its way into med school, for just a lack of a better term?
I think very little. Like a lot of the med students and the psych residents are interested. They're asking for more of this, but it hasn't yet really infiltrated the curriculum.
So can they take a course on it? Or is there a single course?
We do lectures. So for the psychiatric residents, like there's some core lectures that are built into their training at different points. I don't think there's a lot at the med school level yet that I'm aware of.
Yeah, it's interesting.
Interested students do electives with us.
Understood. It's interesting. I wonder if, in general medicine, there's a lack of like nutrition being studied or being taught. I wonder if there's more happening from what I understand. I wonder if this one day will find its way into it like that as well.
The students are really interested in it. They're really keen.
Okay, so
I'm seeing interest. And I think that we need to build up better programs that are integrated with what's already happening.
So speaking of that interest, where do you think this interest is coming from? Because I think you would agree. I mean, you see it firsthand. You just said that there's been an explosion in interest.
Yeah.
Why is that?
Sometimes Michael Pollan's book, Change Your Mind, it was actually huge for the culture. We call it the Pollan effect.
Oh, really?
Yeah. There's a lot of people
It's a great book.
And it really opened their mind to these possibilities. And I think that it's just, psychedelics are having a moment, mushrooms are having a moment. We're seeing it in popular culture. We're seeing documentaries. Patients are asking about it. So it's kind of in the zeitgeist right now. And so I think students are hearing about it. And they're keen to learn about new modalities that can potentially help their patients.
So what do you think the most important lesson is? What can we learn from this long arc of history, going from super common integrated into society thousands of years ago to virtually disappearing, and now it's coming back? Is there a lesson to be learned there?
I mean, I think one thing that comes up for me when I think about doing this work is just humility. Like, these are really powerful medicines. They're powerful technologies. They're disruptive to certain paradigms. They're very, very different. And we need to remain really humble. There's so much we don't know. We need to really carefully pay attention to who it works for, who it doesn't work for, the adverse events. I think we need to listen to the patients who've gone through these trials, who are really, they're the pioneers. They're handing us their consciousness. It takes incredible trust and vulnerability. And so I think we need to listen to them and integrate them more into systems of leadership and understanding as the psychedelic ecosystem continues to grow.
So I was just going to ask, the ecosystem continuing to grow. What are some of the things on your radar that we might not have yet heard about as lay people in terms of compounds or medicines or plants that might start creeping up into our consciousness?
Yeah, I mean, there's a lot going on. So there's a lot of research on newer chemicals, and people are designing psychedelics that don't have a subjective effect, for example, but still induce the neuroplasticity, which might be the right fit for some patients.
What do you mean by subjective effect?
So when you take a psychedelic, you have a trip, right? You have an experience, perceptual changes, a visionary state, you're high.
Yeah.
And some people think that's a barrier to mainstreaming. I would disagree with that. I think that we need to support people, and often the subjective effects, like the mystical experience, we actually see that when people have a mystical experience, when they connect to something bigger than themselves, that positively predicts therapeutic outcomes. But there is research going on to create chemicals that you don't trip, but it still induces the neuroplasticity. Right. So that's happening. There's work happening with ibogaine, which is something
the
iboga root that comes from Gabon in Africa. It's a very, very potent psychedelic. But what's really interesting about that molecule is it can rapidly detox people safely off of opiates.
Yes, it's a huge problem.
Yeah, and it's showing, I think it has tremendous potential for treating opiate addiction and really any addiction. So I think we'll see more research. And we actually saw some of the money from the Sackler, the Sackler family, from those lawsuits is actually now being invested in Texas and Kentucky in ibogaine research, which will help people affected by.
Which I think Governor Rick Perry had.
He's been taking a big interest. It can be a bipartisan issue, which there's very few of those these days.
Yeah, right. Which is strange, because you're dealing with how non-bipartisan could you get, right? Have you had ibogaine creep into your clinic? No.
There's trials. Like I think there might be trials starting in Canada, but not at UHM where we work. Yeah.
Right. So looking forward, what do you see as being the biggest challenge in getting this to become more mainstream as a therapy?
Yeah. I think, in a way it butts up against some of like the old paradigms.
Yeah.
So, in a lot of like biomedical Western psychiatry is, the patient comes to the doctor who's considered the expert, and we diagnose you and tell you what's wrong with you and then give you a pill, and either works or it doesn't work. In this model, you are the expert on you. And we're actually giving you medicine with support to go inward and figure out. So it's like you are your own healer. So it's ultimately very patient-centered and very empowering, but that shakes up this paradigm. And so for power structures and institutions and certain people in the field, that is a challenge. And how do we integrate such a different model?
Yeah.
To me, really, this work also includes a spiritual dimension. Like when we're training residents, I always tell them we look at the biological causes, psychological causes, social causes, but I would say also spirituality. A lot of when I say spirituality, I mean in the most general sense of just being connected to something.
Right, not a religious
bigger. Yeah. So it could be religious faith, but it could also just be what's meaningful to you. It could be a connection to nature. It could be community. It could be connection. And what we're seeing with psychedelic therapy, and one of the ways that it works is it increases connectedness. So connectedness to the self, to others, and to the world outside of you. And so how do we incorporate that dimension of healing into a system that's very focused on the biomedical?
So you said connectedness, which is interesting because these three compounds that we've been referencing are known to do that as opposed to being dissociative.
Mm-hmm.
So is that one of the reasons why do you think is that one of the reasons why these three tend to be so?
Yeah, I mean, ketamine is a dissociative, but it's a little bit different, but it can still be quite a connective experience, and it has a transpersonal effect. But really all of them, like what we see is they start to soften the normal parts of the mind, the sort of defensive structures, the voice in your head, that gets quieter. And you start to be more connected to your own kind of deep emotions, past memories, really understanding yourself in a different way. So that's the connection to self. And then, psilocybin, the messages again and again are often that come through are ones of love, connection, what's really important, what's meaningful, what you value. The MDMA, it's often a lot of processing of trauma, but in this very heart open way with a lot of self-compassion coming online. So it really dissolves shame and allows people to work with their trauma without being so either dissociative or flooded by it.
So how much do you think about the efficacy, the way these compounds work? Because you're describing, I'm sitting here as a molecular biologist and you're sitting there as somebody who deals with people and their emotions and their experiences. How much do you think the efficacy of these drugs is more of a product of the experience rather than what's happening inside of the cells in the body?
I actually think
it doesn't matter.
I think that it's happening on all levels, actually.
Yeah.
And something is happening. Like there's different neurotransmitters are connecting, different receptor pathways are opening. It's shifting brain states and big systems in the brain. Like when we see the quieting of what's called the default mode network, which is like the conductor of the brain. So now if you look at someone's brain on psilocybin, all these different parts are communicating and that's lighting up. And that then is one level, that's the biological level. And then there's a psychological subjective effects component of that same thing. And then there's also a spiritual component. So to me, they're actually just different levels of the same thing. And it actually works on all of these levels. And we can go in and study different levels and intervene at different levels, but they're not actually separate in the way I look at it.
Yeah, that's super interesting. Now, what was I going to say? I had a question. Oh no, you were mentioning the shifting of the power structure and the shaking of the paradigm. It reminds me of when the printing press was printed. You had said you become your own healer rather than somebody healing you. Printing press came along, now you could read your own Bible. You would need to consult somebody, right? So it's the first thing I thought of when you mentioned that. What would your advice be to students going through med school who have an interest in this and don't know exactly how to get involved?
Mm-hmm. That's a great question. I always tell people that are really keen to become a psychedelic therapist, like, first figure out which type of patients you want to work with and get really good at treating them without psychedelics.
Is that a common thing for psychiatrists to specialize in one
Not
type?
necessarily. There's lots of generalists, but let's say you want to do psychedelic therapy. There's like a big difference between end of life and PTSD.
Okay.
So what I've seen sometimes is people really want to be psychedelic therapists. So they end up in the PTSD world, but they're not good trauma therapists first. So what I'm saying is if you're going to treat PTSD with psychedelics, first you really need to understand trauma and how to treat it without psychedelics.
Right.
And then you can add the more subspecialized skill set. Yeah.
So would having supply and demand, would having more psychiatrists interested in training this move the science along quicker, further?
Yeah, I mean, I think the more interest we have, that helps. We have training programs. People are really interested in learning more. I think the science is moving along, and we're going to get there. I think, we'll see what happens with MDMA, but I think it could end up, there could be a resubmission and end up getting approved in the next couple of years. I think psilocybin is probably 5 years out, maybe, for becoming a prescription medication. So I think we need to be getting medical doctors ready, and it won't just be psychiatrists, family doctors, palliative care, oncologists, addictions medicine specialists. There'll be a variety of specialists that'll be involved in the prescribing, and then it's very much an interdisciplinary modality. And so I think we'll work in interdisciplinary teams. We'll have physicians who provide the medical screening and medical oversight, and then we'll have psychotherapists, psychologists who may be doing the therapy.
So where do you hope to see the science or the industry, for lack of a better term, let's say 5 years from now?
Yeah, it's interesting. Like, I think we may see that it is close to becoming a prescription treatment. It's not, I'm not going to say prescription drug, because I think it will be, I hope that it's prescribed as something that can only be delivered with therapy. In a way, it's like people have argued, some of the field is really interested in just the molecule, and there's studies that are kind of removing the therapy or trying to reduce it. Others are arguing we should look at this as like an anesthetic, which like cannot be used without surgery. But I'm probably more in that camp. Like, to me, it's psychedelic therapy. And so we'll see. I think we're going to see research actually proceed down both lanes, and whether we see that it's actually more effective to have therapy. That's my bias. That's what I believe. But we need more science. I hope we see more group. One of the challenges is this can be quite a resource-intensive treatment, and mental health is often not included in the public healthcare system. A lot of psychotherapy psychologists, at least in Ontario, are typically in the private system. And so how are we going to make this affordable? And one of the ways is to do some of the prep and even the dosing and integration in groups. And for some indications, that can actually potentially be even more effective. Like, there's something really healing about the group container and the community.
Right. Especially, I mean, I would imagine if you're dealing with PTSD, with trauma, that's a product of being in a group.
Yeah.
Firefighters, police, soldiers, that sort of thing. Right.
The other thing that I think the field's struggling with is there's been a real lack of diversity in some of the early clinical trials. So I think we really need to think about how do we increase getting this to BIPOC communities, other marginalized or vulnerable groups. I just don't want to see this just becoming a treatment for people who can afford it.
Is that where it's
firstly a lot of the private clinics, where you can do special access program or, ketamine are often private pay. So it's for people who either have insurance through working or can afford it out of pocket, which is, it's very expensive. It's be like $1,000 for a single treatment.
Oh, really?
And so I just, I don't want this to further entrench these social structures, which create so much suffering. Yeah.
This might sound like a weird question, but it just occurred to me. How young do you go? Is there a lower
question?
limit?
Typically, like, most of the trials have been 18 plus. But for phase 4, which is after phase 3 trials, for example, once MDMA gets approved, there's post-marketing phase 4 trials that will go down to 12 years. So they will actually have to trial it in adolescence.
Interesting.
Yeah. So we don't know how will that interact with the developing brain. What are the risks there, but also could there be potential benefits of treating people when they're younger so that they can get healing at a younger age? So there's a lot we don't know.
I had a situation in the park with my children recently. They were getting dizzy on a roundabout, on a thing that you spin around, right? And it occurred to me, oh, that might be the first time in the human's life where they have like an inebriating, mind-altering effect is when they're getting dizzy in the park for the first time.
Yeah.
Just a silly observation.
It's interesting when you look at like the way a brain lights up on LSD, for example, and all these different parts connecting.
It actually looks exactly like how an infant's brain lights up.
Oh, really?
Yeah. So it's almost like kids, before their sense of self, like that, the ego doesn't fully form until like 7, 8 years of life. So children are in this like open state, in this sense of awe, and they're more emotional. They're kind of like tripping all the time.
Yeah. No, that's just true, because I never understood the term a child is naive until I had children. And that's exactly what you're describing. They don't have an ego. They don't know where to place themselves in the world. They're completely naive and innocent.
And open.
And that is very interesting that the two brains look
very similar in how they light up. Yeah.
Do you see that happen, the lighting up happening in older people? Let's say 70 plus, 80 plus, do their brains light up the way young children?
They still on a psychedelic.
Yes.
Yeah, they can be more sensitive and there can be more side effects and stuff, but there have been trials. There's a trial going on at ChemH for mild cognitive impairment using psilocybin right now. So there's research happening. There's a trial at Johns Hopkins that was looking at like the early phase of being diagnosed with Alzheimer's. It's often a time where there's a lot of depression, even suicidality. And so they're targeting psilocybin, not so much for the cognitive aspect, but for the distress that comes with that kind of diagnosis.
Do you see in your practice, in your work with patients, positive effects that you perhaps were not expecting? For example, you often hear psychedelics, cannabis make you more creative. Like, do you see that coming out?
Absolutely.
Unlocking of potential that was not there prior?
Yeah. So we really see that, like, it's not just about alleviating suffering and reducing distress. It's really about well-being and thriving. And so I've seen multiple times like creativity come online. Right. People start singing again. They're drawing, they're writing, they're reflecting on what's meaningful. They want to give back. They want to they start volunteering. So we really see people actually start to thrive. So it's taking the healing to the next level. And we try to work with them in the integration of like, how do we help them operationalize some of that so that some of those new patterns and ways of relating to the world and others can kind of, become more solid as they go forward.
Do you have any particular cases that have stuck with you that you can speak about anonymously?
Yeah. There's one of the very first patient that I gave psilocybin to. She was a mother of 3. She was in her early 50s and she was dying of colorectal cancer. And she had a lot of unprocessed grief, and she hadn't actually been able to tell her kids that her chemo was palliative and that she was dying. And they were about 18 to 22 at the time. So she took this high dose of psilocybin. We did prep sessions. There were 2 therapists. She took this high dose of psilocybin. She had an incredible experience in it. She felt that she was dying into love and she completely lost her fear of death. She felt that she was met by her brother and her dad who had already passed, who were going to be there waiting for her. She said that death is actually just a transition. It's nothing to fear. She processed so much grief in that session that right after she was able to start saying goodbye to people, telling her kids that she was dying. And she had just like a major transformation. She died about 6 months after that. But previously, she said cancer was running this final chapter of her life. And after the psilocybin, she said she was running this final chapter. She started meditating. She got back in nature. Wow. She was able to say goodbye to people. And so it really eased the suffering that she was experiencing, and it allowed her to have a better death. And then that rippled out to the family, and that really supported their grieving process.
Was that after 1 dose?
Yeah. Single high dose. Yeah.
Wow. And is that, I don't think there's any other, correct me if I'm wrong, compound or medicine that after 1 dose, you have
it's pretty amazing.
Lasting effects.
Yeah. And especially in the end of life population, we find even a single dose can endure. They're not for everybody. There's some who would really want a second dose or who could benefit from that. But for a good proportion of the patients, a single high dose with the therapy at the end of life is incredibly transformative.
And is that a common? I would imagine that's the sort of result that you're hoping for. Is it common?
In the end of life population, yes. Yeah, I would say it's common. In treatment-resistant depression, I think we're still figuring out how long the effects last. So, for some patients, like it's pretty common to get an antidepressant effect, but it doesn't necessarily last. So that effect could wear off after a couple months. So maybe that people need multiple doses. They may need booster sessions, like compared to taking, say, an SSRI every day forever.
Sure.
Even if you had to get every 6 months, go get your psilocybin, that, could potentially be better for your brain.
So certainly there's going to be somebody listening to this that either knows somebody or they themselves, they think might be good candidates for something like this. How does somebody get involved? To me, it seems insurmountable. Like I wouldn't even know where to
it's
start.
Really challenging. It's still like access is still a huge issue. So our program, for example, like we're only currently treating patients who are at the end of life. So either patients with advanced cancer. We also have a sister trial for their loved ones. So we're giving their caregivers their own psilocybin experience. So you can check us out at the UHN Psychedelic Psychotherapy Research Group, and you can see about our open trials there. There's another group, part of the Paul Hansen Center for Depression at UHN, that is studying psilocybin therapy for depression, for bipolar depression. So that's also happening. And you can also check out clinicaltrials.gov. And if you put in like psilocybin in Toronto, for example, it'll show all of the clinical trials that are accepting patients in Toronto. So there's a number of different active ones that are happening at CAMH right now.
And I did that earlier today. And around the world, there's about 200, 180, 190, something like that.
There's a lot.
That's a lot
going on around the world. So you can look at which ones are in your area if you have a particular condition. And then there are ketamine clinics that are available throughout the city. A lot of them are more private pay and they can be expensive. But that is one of the other ways that people can access it right now.
So do you have, what would be your parting words for somebody who is on the fence regarding this? You said it's a bipartisan issue. It can be a bipartisan issue. It's not even along political lines, but just some people, when they hear psychedelic therapy, count me out.
Do you mean like the stigma?
Yeah, because I guess it's the stigma that's preventing them from even considering this.
Yeah, I mean, like, I would say, like, for an individual who's thinking about doing it for themselves, like you want that to feel like a full yes, and that it's like a real call and this is in alignment with you and your values. But I would encourage those, if you're not necessarily considering it for yourself, just to question your stigma. Because I think we've had a lot of anti-drug conditioning and some people just hear psychedelic and it's an immediate no.
Exactly.
But I think what we're seeing is in clinical conditions with a lot of attention to creating safe conditions, we're getting really promising results and a totally tolerable safety profile. And so for the right patients, for the patients who are ready for this deeper work, who are stuck and have tried other things and it's not working, I think this is a viable option. It's still experimental. So that's really important to remain humble. As I said, there's a lot we don't know, but I remain cautiously optimistic. This is just one novel treatment within psychiatry and medicine. There's lots of, new things that are being explored. This is the path that I'm on.
What I find interesting is that at the same time, when interest in psychedelic therapy is going up, you are seeing a bit of a decrease in interest for things like SSRIs, or the idea of overprescribing is sort of coming into the fold.
Yeah.
So it's interesting that we're at this point in time where there's this inflection point between the two.
Yeah. I think people are looking for newer treatments. That the current treatments are unsatisfactory for a lot of people. And I think that we owe it to our patients to keep researching and seeing what else we can find to support people to heal. Well,
Emma, that was fascinating. I learned a lot. Yeah. Thank you so much for joining me.
Yeah,
and I wish you the best of luck. And I hope that this progresses as far as it should, whatever that might mean. But it looks very promising.
Yeah. Thank you so much.
Thank you very much.